what I want to welcome. Good afternoon. I want to welcome everyone to what a series of seminars that we've been putting on virtually for the university and beyond audience interested in issues of aging. A few weeks ago, we had a very informative sessions on some of the biological aspects of aging, mostly in the neuroscience area. And today we're going to talk about some of the psychosocial issues in aging as part of our Center for Research on Aging. For those who don't know a lot about the center, let me just give you for a very short overview. Many of you have seen this many times. Some of you maybe not seen it at all. The center is led by myself and Alice Ryan, who is our Associate Director for Translational Science. And the center is based on a principle that aging research and training are inherently interdisciplinary, and that care requires interprofessional cooperation and collaboration. We've operated up until now as a center without walls, meaning anyone who is doing some serious research is welcome to be part of the center. Currently, there are 165 faculty from across the campus and a few people from outside. When we tally up the research funding of those 165 faculty, we come up with about $74 million of new funding that was in FY22. We'll tell you that again in June. And our mission is to facilitate research and research training in aging. There's a leadership group which has representatives from all of the schools on our campus, with an administrative core as well. And here I've represented, can you see these or they're not moving? There, that's about the center. And there's the leadership group. Okay, this diagram, which is on our website, depicts all of the programs in aging that we're aware of that have some alliance with the center. There are research programs, and then there are training and education initiatives. All of the schools on the campus have some involvement in the center. There's also involvement from other campuses, the VA, and the National Institute on Aging. This is how the affiliates are distributed. Most are in the School of Medicine because the School of Medicine has the most faculty. Proportionately, it may not have the highest proportion of those doing work in aging, but this is the distribution according to the center. And funding-wise, we started back in 1998 with very little funding and have built up over the years to a fairly steady growth pace. So Stender's doing well. We keep operating as we are, and hopefully there'll be continued growth in the years ahead. Today, we're fortunate to have three speakers. We're going to talk about different aspects of some of the psychosocial aspects of aging. I'm going to take my screen down and introduce our first speaker, David Camacho. And Dr. Camacho is an assistant professor in the School of Social Work here at the University of Maryland. He earned his PhD in social work in advanced clinical practice at Columbia University and completed doctoral training in behavioral geriatrics at the Weill Cornell in the Department of Medicine and Geriatrics and Palliative Medicine. He also has a Master of Social Work and a Master of Science in Gerontology, both degrees from the University of Southern California. His research centers around the physical and mental health of racial and sexual minority older adults in the United States and Latin America. And his research agenda includes gaining a deeper understanding of loneliness, chronic pain, and cognitive impairment among diverse older adults, with an emphasis on identifying and accelerating the implementation of promising interventions into real-world settings. So I'm going to turn this over to Dr. Camacho to talk about some of the work he's been doing.
Well, thank you so much for that introduction. I was asking myself, who is that? But let me just now share again. We have 14 minutes or so. Is that approximately it?
Anne, is that right?
That's right.
Okay, so I'm going to skip over some of this, but basically for today, I'm going to be talking about an ongoing project where I've had the opportunity to engage older Latinx individuals in discussions or narratives related to loneliness, experiences of loneliness. This is a project that was funded through the Columbia Center for Interdisciplinary Research at, the CIRAD at Columbia. Also the Triple Center at Cornell. This is through my mentors, Dr. Reed, Dr. Wethington. I need to acknowledge my research assistants. Two of them are at NYU, but Todd Becker is currently a PhD student about to finish here at University of Maryland. And of course, I must thank my participants because without them, we couldn't do this. For those, I'm probably speaking to the choir here, but in terms of loneliness, we know that loneliness is a significant public health problem in older adulthood across the life course. And it's associated with worse health outcomes in terms of depression, cognitive functioning, earlier mortality, et cetera. But there are major gaps in the literature, and part of that is that the literature has not really acknowledged the experiences or created understanding of loneliness in the increasingly diverse and growing Latinx population in the United States. We come from 20 plus different countries. Yes, we speak Spanish, we speak English, but we also speak other languages. And this community or group of communities also includes sexual and gender minorities that are hardly acknowledged in the literature. But there's plenty of reason to believe that the experience of loneliness may be different due to cultural factors, the experience of minority stress, and thinking about cumulative inequality, the exposure to risk and opportunity across the life course. So for this project, the basic question was, what are the lived experiences of loneliness in older Latinx individuals? And I recruited older Hispanics, 60 years plus. We screened using the UCLA loneliness scale. These were individuals with no cognitive or no significant cognitive impairment. And we collaborated with social service agencies in Los Angeles, New York, and Baltimore. I'm going to skim through this, but basically the interviews were guided through a cultural formulation interview from the DSF-5. Also, a lot of emphasis on engagement, thinking about trauma-informed, thinking about how to build trust with these community members. Because part of this project happened during COVID, interviews happened via phone and also in person later on. In terms of the analyses, in a very general sense, we engage in a thematic analysis, thinking about relevant theories, thinking about what really stands out in terms of the emotions, what plays to the emotions, and thinking about reflexivity. How do we really shape the way we understand these individuals' experiences? In general, we had 26 individuals, average age was 70. Most were women, mostly low levels of education. 60% had less than a high school education. 40% had less than a sixth grade education. Most of them had less than $12,000 as a household income. Most had some type of insurance, but there were 2 or 3 individuals in the entire sample who had either emergency Medicaid or no formal insurance. A lot of chronic conditions, a lot of them had chronic pain. More than half of them had based on the PHQ-2, significant cardinal symptoms of depression, or at least one of the cardinal symptoms of depression. So either low mood or a lack of interest, pleasure in enjoying their activities. Now, I'll jump to the findings. And in terms of, this thematic analysis is an ongoing process. There's a lot of these narratives are very complex. But in terms for this presentation, I will focus more on the perceived causes and contributing factors to loneliness that individuals talked about, and also their coping strategies. And I'll touch on first on descriptions and the impact that these individuals described. One key piece to understanding these participants' narratives is really, it was very obvious that there were a lot of cultural factors that shaped the way people understood experiences of loneliness. So familism was very clear. Gender roles or expectations of what a man or what a woman should be behaving, how they should behave. Bereavement processes definitely shaped experiences of loneliness, but also these related to religious beliefs. Fatalism, God is in control of my life and he's the one that's in charge, I'll live as long as he wants. Definitely the role of immigrant stress. So documented status, undocumented status was important for the individual, but also family members who were undocumented. And then not surprising, poverty, education, and violence were issues that also came up. Some of these individuals were interviewed in the Bronx and not so nice areas in Los Angeles. So not surprising, rates of crime were high. And because this was done during COVID, COVID definitely shaped these experiences as well. In terms of their descriptions of loneliness, the majority of the descriptions related to what Wise would call as emotional or existential loneliness. So the sources of loneliness had to do with strained relationships with family, romantic partners, or lack of a romantic partner. And the more interesting one was this lack of connection to society, not having a role in life. They felt that disconnected, they didn't see a purpose in continuing to live, basically. For some of these individuals, disclosure was a problem, acknowledging there was shame in disclosing that they felt lonely. Some of them felt that they shouldn't feel lonely because they were surrounded by other individuals. And in terms of interpretation, some individuals felt that this was a normal part of aging. It was expected. And ultimately, loneliness is a problem relative to other ongoing challenges in their lives. And in terms of the impact, very much in line with literature, they described the impact it has, negative impact on feelings of depression, worsening pain, so intensity of pain, frequency of pain, suicidal ideation for some, and increased feelings of stress. Definitely loneliness impacted or decreased motivation in terms of social functioning, limited goals for the future, limited interactions with others. And even though they claim that some of them, the sources of loneliness were strained relationships, the feelings of loneliness themselves further strained relationships. So it was a bidirectional relationship there. And just some examples. So the first one here was a 78-year-old man actually from Baltimore, from El Salvador, living in Baltimore in a basement in Baltimore City with 10 other individuals, including his wife. Yet he felt that he was abandoned by the world. He started off his interview by saying that to me. And then two, we have a 72-year-old woman who lived with her daughter with special needs. I believe she had intellectual disability and or autism. And anyhow, she said to me that initially she said she didn't feel lonely because she lived with her daughter, but the more she talked, she acknowledged that she felt lonely. And she said, sometimes you feel alone when nobody visits you or anything, talking about specifically her other daughters who didn't come and didn't care about their sister with special needs. And then a 79-year-old woman basically said to me, look, I do not have any desires for the future. I wish only that God allowed me to live and I continue my life. It's very much in line with other literature talking about loneliness or describing loneliness as an empty waiting room where you're basically waiting for death. Probably the more interesting, and this is me thinking more interesting, the perceived causes and contributing factors to loneliness. It's highly personalized. There is no one factor that contributes to loneliness only. If individuals discuss multiple sources of loneliness, recent sources of loneliness, and also long-term sources of loneliness. I'll provide some more examples. One of those is like a mismatch. And this had to do with cultural factors where individuals were very family oriented, but their children and grandchildren who grew up in the United States applied or took on more individualistic perspectives of life. So there was a mismatch in those social relationships. A history of domestic violence. One woman, for example, talked about not wanting to socialize because the first thing you're asked is, are you in a relationship? Are you with a partner? And she doesn't want to relive or have to talk about the experience of domestic violence as to a reason why she's not with somebody. And then adverse childhood experiences, there's some growing literature describing some of this, and I'll provide some examples. For example, again, this Mexican woman talks about, look, my childhood was sad because first I lost my mother. She was the best thing, o sea, lo más grande in my life. My father, he gave us away. My sister and I do not even know where she ended up. I alone have had to take care of myself. So this woman very early on eventually migrated to the US and she basically raised herself. She lived on the streets and she found a way to the United States as a way of surviving. And then the 68-year-old woman at the bottom talks about missing her husband. Every day I tell my daughter that I miss your dad. It's been close to 19 years since he died. So this pretty much is along the lines of, some people might say complicated grief or prolonged grief disorder. But this is something that also strained the relationship with her daughter. Her daughter would tell her, you know, you need to find a boyfriend or you need to find some friends. This is why you need to go talk to them. Don't talk to me anymore. So that strained the relationship further. And then this 60-year-old Dominican woman, also undocumented, talks about, you know, this was during the pandemic. They lived in a home and they were separated because of the pandemic. She said, to start, look, I feel alone. After we were separated, we lived together. My daughter, my grandson, and me, we were in a house. When I got to the shelter, it was the last straw. I did not know what the word shelter meant until I learned it firsthand. It has been since then that I felt uncomfortable, referring to lonely, feeling depressed. And this had to do with, basically, she was assigned to a shelter in the Bronx, and her daughter and grandson were in a shelter in Queens. So that distance, that physical separation contributed to her feeling completely isolated and lonely. And in terms of coping strategies, again, a wide range of these spiritual coping strategies, cognitive coping strategies, behavioral coping strategies, and some examples of these. Oh, in counseling, there was one individual who had the opportunity to receive counseling to address feelings of loneliness and depression and other issues. This 70-year-old woman talks about how it is all relative. She says, well, yes, doctors told my children that I was not going to live. She is a survivor of 3 strokes. So that really shapes the way she sees the world. The doctor told her that I was going to be a vegetable, but look, I'm here speaking and all. I have gone through so many pains and that is no longer which one is stronger or weaker. I have gone through so much worse pains and they have resolved. And with God's will, as long as I have my supports and they help, I'm grateful to God all the time, all my life. Again, demonstrating how this is all relative, especially with all the health challenges that some individuals have. They cannot really spend so much time thinking about their feelings of loneliness.
David, about 2 more minutes.
And we have like 3 more slides. We're almost there.
Okay.
And in terms of this other coping strategy, I'll skip this one. Even it's cognitive, but basically he tells himself there's a lot of positive self-talk. This last one is probably very interesting. It's this woman talks about what bothers me the most about loneliness is not accepting it, not making it her, my friend. There's a personification of loneliness. I need to accept her as my friend because I live with her, I sleep with her, I bathe with her, I walk with her. If I did not accept her as my friend, I would go crazy. So there's the personification of loneliness as a way of having a companion in order to fight that loneliness, accepting it as part of her life. So what does this all mean? Well, in a very basic sense, the idea here is to show and to consider that culture and contextual factors matter in the context of loneliness. We need to do a better job of how we assess loneliness in terms of how we measure. Loneliness isn't something that is easily disclosed. There are different types of loneliness. They definitely impact functioning. And we need to start thinking about how we develop interventions that address the sources of perceived disconnection, primarily family. We definitely need to think about the existential piece in creating roles for older Latinx individuals. These individuals are not going to go back to work. They're not going to provide volunteer services at an office or social service agencies. We need to think about their skill level. And ultimately, we need to find ways of enhancing coping mechanism and management resources for these individuals. So in other words, there's a lot of work to be done in this community, and that's where I'm at. And I will stop there. Thank you so much.
Thank you. Thank you very much. Very interesting, in-depth look at what goes into loneliness in this group for sure. Let's go on to the next talk and then come back at the end for any general questions. And the next talk is by Dr. Amber Kleckner. Dr. Kleckner is an assistant professor in the School of Nursing at the University of Maryland. She has a Master of Science degree in biochemistry and a PhD in human nutrition from the Ohio State University, and recently completed a fellowship in supportive care in cancer from the University of Rochester. Her lab designs nutrition-based clinical trials to address cancer-related fatigue during cancer treatment. Her dietary interventions include both composition and timing factors to address mitochondrial and circadian mechanisms underlying cancer-related fatigue. She has more than 50 publications and is currently funded by the National Cancer Institute. Dr. Kleckner.
All right, thank you. As you said, my name is Amber Kleckner, and I'm an assistant professor in the School of Nursing. Today, I'm going to be talking to you about time-restricted eating to address cancer-related fatigue in cancer survivorship. Yes, so as you know, cancer is an enormous burden for many people and the US as a whole. It is expected that 40% of Americans are going to get cancer in their lifetime. So that means that there's a 40% chance that you will get cancer, 40% chance I will get cancer. That's really scary. Also, national estimates of cancer care are at $208.9 billion in 2020. That is a 10% increase from 2015 after adjusting for inflation. And that increase, it's climbing very rapidly. And that increase is due to both the growing US population and the aging population. That's the bad news. The good news is that with amazing advancements in therapeutics, the 5-year survival rates for cancers are climbing. For example, breast cancer, if the tumor is localized to the breast, non-metastatic, 5-year survival rates are 99%. So that means that there are more cancer survivors now than ever. It's about 5.2% of all Americans are cancer survivors, and 61% of Americans older than 65 are cancer survivors. And as I said, the older population is growing, and this phenomenon in geriatric oncology is known as the silver tsunami of cancer survivors that have a lot and unique medical needs. It's, oftentimes they don't just have cancer, but they have also many other comorbidities that the health system is going to have to deal with, is dealing with now and is going to continue to be dealing with in greater numbers in the future. Unfortunately, people are living with persistent symptoms, side effects, and toxicities of cancer and its treatments. For example, cancer-related fatigue, cognitive impairment, cardiotoxicities, pain, and neuropathy. A lot of these symptoms cluster together. It's rare to find one without the other. And when people have these long-term side effects, it affects their ability to return to work, to return to family roles, to return to hobbies. And people have to redefine their identity, and it really reduces quality of life. So for this reason, supportive care in cancer is a high priority at NCI. So cancer-related fatigue is very common and very burdensome. It affects almost all patients who undergo chemotherapy for cancer treatment, also almost everybody who undergoes radiation. It is not like normal tiredness in that it can't be relieved by rest or sleep. It can greatly impair the ability to do activities of daily living and therefore greatly reduce quality of life. As I said, fatigue can persist for months or even years into survivorship, and we have very little to offer patients there. We have very few effective preventive agents and treatments for cancer-related fatigue. And this is in part because we don't understand the etiology or the pathophysiology of fatigue. We don't understand why it happens or what is happening on a molecular level that manifests in the feeling of fatigue. So that is the bulk of what we're doing in our lab. I am a nutrition scientist by training, so I'm very interested in using food as medicine and helping to design trials to test some of these theories, to get some nutrition recommendations into guidelines so that people know what to eat and when to eat in order to help mostly relieve their symptoms. So intermittent fasting the research on intermittent fasting has exploded in the last decade or so. And this is a figure from our recent review paper that was just recently accepted at JNCI monographs. And what it's showing is the plethora of mechanisms that intermittent fasting might work through to address various oncology outcomes. So fasting specifically can, of course, stimulate postprandial energy metabolism. So through various hormones and other nutrient pathways, just not eating can stimulate some of these things. And then also circadian rhythm processes. So our lab is mainly focused on circadian rhythms. Circadian rhythms are 24-hour cycles, and most tissues are regulated actually on a circadian basis. So our hypothesis is that if you eat all of your food, so food helps regulate circadian rhythm along with light and exercise. And if our hypothesis is that if you eat all of your food within a 10-hour window during the day, which 10 hours, isn't even that short, it can be like 9 a.m. to 7 p.m. If you eat all your food within that 10-hour window, it'll help people sleep better at night, have higher quality sleep at night, and then have more energy during the day. So we are implementing this sort of circadian rhythm in training intervention with eating, and we are thinking that it's going to work through a lot of different, it's going to help regulate circadian rhythm of lots of different tissues, including the pancreas, the adrenal glands, to just help the non-cancerous cells function better and be able to withstand a lot of the treatments that people are enduring during cancer treatment. So when we first started this study a few years ago, there hadn't been any time-restricted eating studies in the cancer population. So we did the very first step. We were wondering if people were willing to join the trial, and if so, are they able to eat in a time-restricted manner? And then we also assessed safety and just within person pre-post changes in fatigue. So this study was conducted at University of Rochester, where I did my postdoc, and it was conducted during COVID-19. The whole thing was done remotely. We recruited people by mailing letters to their homes. We recruited cancer survivors who were 4 months to 5 years post-treatment, who typically consumed calories within a window greater than 10 hours, so that this was a change for them, and people who were experiencing fatigue. At baseline, we administered questionnaires, 2 multidimensional fatigue questionnaires, as well as a symptom inventory. They completed a 24-hour food log and logged their body weight. Then everybody underwent the time-restricted eating intervention. The 10-hour window was self-selected. We just asked that it was consistent every day for the 14 days. They completed daily diaries and recorded their body weight at day 8. At day 14, they completed another 24-hour food record. And then after the intervention, we administered the same questionnaires that we did at baseline, and we conducted an intervention evaluation where we probed barriers and facilitators of their adherence to time-restricted eating. So we showed that recruitment was indeed feasible. We recruited 39 survivors in 14 months. Most of them had had breast cancer, 3 had had prostate cancer, 1 had had uterine cancer. And this is just because we had a good relationship with the people at the breast cancer clinic. Most of our participants were female. The average age was 61.5 plus or minus 12.5. Patients were on average 1.7 years post-treatment. And indeed, time-restricted eating was feasible. Our participants were able to do it. We only had 3 people who were lost to follow-up, so 92% completed all of the study assessments. 86% had an average eating window of less than 10 hours, which was the prescription. And then the average eating window was 9 hours, 20 minutes. We emphasized that this was not a weight loss study, but participants had their own goals. So on average, body weight decreased 1 pound, which of course is not any area for concern. 1 pound in 2 weeks is totally fine. It was statistically significant, but there was no severe instances of weight loss, and there were no severe adverse events, no severe adverse events at all. And here are our fatigue results. This is the FACIT-F, which is a questionnaire in which a higher score is higher quality of life, less fatigue. We saw an improvement of about 10 points in the 14 days. This is the brief fatigue inventory, in which a lower score indicates lower fatigue. And same thing, we saw about 10 or 11 point decrease in fatigue. So these are moderate effect sizes, which were very encouraging. Of course, this is a single arm study, so there could be expectancy effects. And our next step is to do a randomized controlled trial. So that's what we're doing here at University of Maryland. We are basically planning to do a bona fide phase 2 study. So what we're doing in this pilot randomized study is we're doing all of the assessments we would want to do in the bona fide phase 2 study. So we're recruiting 30 participants, randomizing them 1-to-1, time restricted eating to control. We're conducting a bunch of mechanistic measures, such as circadian activity rhythm with an actigraph and continuous glucose monitoring, so that we can see glucose levels over 24 hours for a full week at baseline, 6 weeks and 12 weeks. And basically testing the feasibility of all of our study assessments. We have recruited 7 people as of today, and this is Grace Adetolu, who is in charge of recruiting these participants. And if I give this seminar next week or next year, hopefully I'll be able to tell you the results of our ongoing study. And this is an aging seminar, so there's a lot of open questions related to the relationships between aging and cancer treatment and fatigue. And older adults indeed tend to have weaker circadian rhythms than younger adults.
Can you wrap up in about 2 minutes, Amber?
Sure. So
Okay.
that begs the question, are older adults more or less responsive to circadian interventions? We noticed in our pilot study that a lot of retirees specifically aren't really on a definite schedule. They don't have any time that they need to be up to be anywhere. So sometimes people would just stay up late watching TV. And then with our studies, I remember one person in particular would tell us, like, I would be up late watching TV, and then I would normally go for a snack, but I wasn't allowed to go for a snack. So I just went to bed. It's like, well, no wonder why you feel better. So I noticed that I think a lot of just getting people on a schedule, whether it's with eating or with just getting people on a regular sleep schedule, could really, really help with this fatigue.
Mm-hmm.
So anyway, this is an open question. And then also another large thing that we have to think about is cachexia, especially in older adults with advanced cancers. And of course, if time restricted eating is leading to fewer calories, that's probably going to exacerbate cachexia. But what if it doesn't? What if people are eating, an adequate number of calories? Could it help reset metabolism? This is a big open question, something that would definitely need major oversight by medical monitors, or maybe even be done in preclinical models first, in my opinion. But there's definitely a lot of open questions here. So I would like to thank everybody who made this work possible, and I'll leave it there. Thank you.
Great, thank you. This is great. This is really interesting. Interesting connection with some of the biological work that is going on throughout the center and campus. We'll come back for questions in a few minutes after we hear from Dr. Michael Lepore. Dr. Lepore is a professor in the Department of Organizational Systems and Adult Health and co-director of the Center for Health Equity and Outcomes Research at the University of Maryland School of Nursing. He's also a professor in the Department of Medicine in the School of Medicine. He's trained as a sociologist, gerontologist, and health services researcher, and now serves as the Associate Director for the Community and Collaboration Core of the University of Maryland, Baltimore's Institute for Clinical Translational Research, and as Associate Editor of the Gerontological Society of America's Policy Journal, Public Policy and Aging Report. Dr. Lepore.
Thank you, Dr. Magaziner. I'm Michael Lepore, and this talk will review efforts toward enhancing access to evidence-based psychosocial services among people living with dementia, which is the heart of a pragmatic trial that I'm currently piloting. And these are my partners, my very valued partners on this trial. It includes a couple of physicians and site coordinators at Yale and at UConn, and Caring Kind, which is a community-based organization headquartered in Manhattan that provides services for people living with dementia. And then Deanna Meyer, now Deanna Kerbeam, who just recently graduated from the University of Maryland School of Nursing, but is continuing to coordinate this trial with me, as well as a statistician over at Brown. Our work with this focus was motivated by the recognition that people living with dementia currently have limited access to evidence-based psychosocial services. In the US, physicians commonly have few options to provide dementia specialized therapies, and often instead have patients with dementia coming back in for cognitive assessments, but without offering them any psychosocial services. Helping to explain this situation, a recent review by AHRQ found that very little evidence supports widespread dissemination of any general care approaches for people living with dementia. So although psychosocial treatment options remain limited here in the US, these options have grown internationally, and the evidence for psychosocial services also has grown internationally. And cognitive stimulation therapy is one such evidence-based psychosocial service which was developed abroad. So cognitive stimulation therapy, or CST, as I'll probably refer to it, was developed at University College London in 2000. It was actually a dissertation, and it was developed as a group treatment for people living with dementia. Its standard delivery involves 14 or more sessions that are delivered about 2 times per week, and each session is centered on a theme. CST is designed to actively stimulate thinking and to engage the participants in a learning environment where they feel safe and stimulated. Research has demonstrated improvements in cognition and quality of life, in mood, in communication, and in social engagement among participants. And in the UK, CST is now standardly recommended for people with mild to moderate dementia, and it's the primary psychosocial intervention that's offered by memory clinics in the UK. It's also now practiced internationally in at least 35 countries. I mentioned there were 14 sessions, and across those 14 roughly bi-weekly sessions, there are common psychosocial goals and objectives, and these are listed down the left side of this slide, including things like elevating mood and promoting social awareness. And then on the right side of this slide, it shows the themes of each of the 14 sessions. Each theme is highly protocolized to follow a certain and consistent agenda, but then each of the sessions does have a different topic or theme. So in this global context, I had the chance through a PCORI-funded workshop, it's the Patient-Centered Outcomes Research Institute, to listen to and actively collaborate with people living with dementia and their care partners about their priorities, and to collaborate with them in developing a prototype study. And 2 key issues arose through this process, including the prioritization of social activity by people living with dementia and their care partners, and the identification of cognitive stimulation therapy as a solution that can support people living with dementia to have meaningful social engagement. It wasn't until 2020 that I'd even heard of CST, as it is not very widely available here in the US. And learning about this near 2020 certainly made gathering people together for a group therapy like cognitive stimulation therapy rather untenable. And so in 2020, we piloted virtual cognitive stimulation therapy using Zoom. We conducted qualitative assessment of participant experiences in CST via Zoom, and we identified themes based on their responses. We actually sent them an inquiry after all of the 14 sessions to get their feedback after each one. And after we analyzed the data and identified themes, we provided the themes and representative quotes to all of the participants. So we had these themes verified by the individuals who provided the data, those CST participants. And ultimately, the results showed that the participants enjoyed participating. They felt a greater sense of confidence from participating. They found the activities to be inclusive, and they really appreciated the current affairs discussions, which are part of each session. And they especially noted in several different comments how they liked the more controversial topics, things like gun rights and gay marriage rights. So building on lessons learned in that initial pilot of virtual cognitive stimulation therapy, we've now secured funding from the National Institute on Aging, the NIA Impact Collaboratory, which focuses on supporting pragmatic trials. So we're conducting piloting a pragmatic trial of virtual cognitive stimulation therapy. And this pilot trial is underway now, and ultimately it links a primary care clinic that's at UConn and a neurology clinic at Yale, both of which see a lot of people living with dementia, links them with this community-based organization in Manhattan that provides virtual cognitive stimulation therapy. So in this trial, the clinics are providing us here at the University of Maryland, Baltimore, with data from their EHRs on eligible patients, mainly including their cognitive assessment scores, which is really the key selection criteria. And then the CBO, Care in Kind, provides us with data on patient engagement in cognitive stimulation therapy, things like attendance and any attrition. So we're then partnering with Brown for data analysis that includes the randomization of the participants into the intervention and control groups. And the control groups receive standard care, whereas the intervention group ultimately receives referral for cognitive stimulation therapy. These are the inclusion and exclusion criteria. I won't go through them all, but I want to highlight a couple of them. Criterion B in the inclusion criteria shows that we were open to scores on any of 3 commonly used cognitive assessments, which helps make the trial pragmatic. But thus far, all of them have been with the MoCA, the Montreal Cognitive Assessment. But having the options of using the other assessments will allow us to do this in more clinics. And with criterion C in the inclusion criteria, the timing of the follow-up appointment. We don't want to lose folks to follow-up, but we also want to not require the physicians to make any special appointments because that's not pragmatic. So it's designed to work in standard practice without any separate or additional visits needed beyond what would occur normally. And then in the exclusion criteria, I'd also highlight criterion B, where we are providing sort of clinical flexibility for the physicians to assess the conditions of the patients that might interfere with participating in CST. For example, if someone is often combative, it might not work well for a group therapy. And then with criterion E, we're also allowing for the physicians to determine whether a caregiver is needed to support the individual's participation. Plenty of people with dementia are unable to sign on to Zoom, but some are able to do that independently. So we didn't want to set that requirement ourselves. We're allowing the physicians to assess that in clinic. So the key steps of our trial is first identifying eligible patients using the electronic health records from the health systems. The screening of those candidates then is done by their physician. And of those who the physician screens in, those are randomized to the intervention or control groups, and then the referral of the intervention group to the community-based organization, and then ultimately their participation in CST, and finally, their follow-up visits to the health systems where the follow-up data is collected. we've now begun, and we are at the beginning stages. So I'm just going to share some preliminary, almost results, but more like enrollment findings. So we've begun the trial, and we actually now have 39 individuals enrolled. 49 patients were identified in the EHR review, but 10 of them were screened out. So just about 20% were screened out by the physician, either because they were deceased, they were no longer active patients at the clinic, they were too impaired, as the clinician determined, the physician determined, or they were on hospice. So our hypotheses also leverage the real world data that we're using, the EHR data. So we're using the cognitive assessments from the health systems. Those are being used both as inclusion criteria, but also as our outcome to see if individuals who participate have less cognitive decline. And then we're capturing the participation data from the community-based organization. And yes, our primary hypothesis is that we will observe less cognitive decline in the intervention group than in the control group. We also hope to see improvement, but that is our secondary aim and perhaps less likely. So in considering next steps for this trial design, I'm going to be seeking to engage health systems with more diverse patient populations. The two that I'm working with now are both academic medical centers in Connecticut, where the diversity of the patient population is limited. For example, in the one clinic that has begun enrollment, 92% of the eligible patients were identified as white. So I'm also definitely aiming to broaden the health system's patient population diversity, and also want to broaden the eligibility pool of patients by partnering with a community-based organization that delivers CST in multiple languages. And the one that I'm partnering with now is upskilling their staff just for that, or actually recruiting new staff just for that purpose.
Can you wrap up in about 2 minutes, Michael?
Thanks, Jay. Got it. So, in considering how to engage additional health systems in this sort of trial, I'm thinking about promoting the multiple returns of value to the partners and to the participants, including the people living with dementia, including the physicians who provide the referrals, and the community-based organizations who provide CST. And I'd really highlight that for the physicians, having an option of providing a referral for an evidence-based therapy has been described by the physicians I'm working with as a real gift to them, as some have expressed how grateful they are to actually have something meaningful to provide these patients, when in previous years, they simply could ask them to come back for another assessment and sort of self-monitor. So I will actually end with that, and thanks for the chance to share.
Perfect timing. Thank you very much, Michael and David and Amber. This is fantastic. I think let's open this up to any questions or comments from anyone. We have about 30 people on, so you could either raise your hand, just speak up, or send a question through the chat.
See Les?
What?
Les raised their hand?
Dr.
Yeah, hi.
Katzel.
Could the speakers talk about the difference between solitude and loneliness?
Can you add in, David, isolation? So I was going to ask you about isolation and loneliness.
So it's interesting enough, this project started off with just thinking about what solitude would translate to in Spanish, and it doesn't. It's literally just translates to loneliness. So Soledad literally means loneliness, and that includes solitude. In English, we divide that into, different perceptions of, being alone, but not in Spanish. So that's an interesting piece to this. But if we're speaking English, then we're talking about solitude. You actually enjoy being alone. Isolation, being separated from others quantitatively. And then loneliness being the subjective understanding, regardless of whether or not you are with other people or not. So that's the subjective understanding.
Because people do tout health benefits and mental health benefits of solitude. That's why I was asking the question.
Right. Which is, it's very interesting, but how do I capture that in a language that doesn't use that word? So,
Well, that's an interesting concept. Yeah, the language is interesting.
yeah.
But
And actually, I'm working with another professor here. We're going to start a review of loneliness in Latin America because most of the work on loneliness has focused not in community dwelling individuals, but really in clinical samples. So even the societal understanding of loneliness is really about people who are at the end of life, who really have very poor functioning, not as a concept that happens among people living out in the community. So there's a lot of work to really understand this concept, clinical concept in Latin America and Latinos in the US.
yeah, sometimes it's not only the being alone, it's also the interacting and being able to move between them. So the control over what setting you're in could also make a difference. Anyway,
For sure.
that's another thought on the puzzle. It's not an all or none. And yeah, other comments on other talks?
If I might ask Amber a question, it was unexpected to see fasting to be associated with quality of life. And I'm curious if you could speak to that some more.
Yeah, sure. So, this is, we're very, very early on in studying these phenomena, and I can just basically say what my opinion is. But I think, especially, so during treatment, people are totally out of control. Like everything is in somebody else's hands. They have to just rely on their doctors. Oftentimes they have to rely on others for transportation or to, do some of the roles that they normally have to do, like working or family responsibilities or whatever. So like so much is out of their control. And I think nutrition in and of itself is very empowering because it's something they can do. It's like during treatment, people are like, what can I eat? What supplements can I take? What can I do to help myself heal? And just that little bit of power that they have, I think just gives them, it can improve quality of life because it just gives them, something that they can do to help themselves. And I think time restricted eating can be a social factor, like a psychosocial factor in that way. And then of course, the very complicated figure that I showed, I think time restricted eating can help regulate circadian rhythm and then can help modulate a lot of the metabolism that goes on, under the surface that can just help people, just help everything move more smoothly, just help people sleep better and eat better and, just have more energy and think better and just kind of regulate that under the surface plethora of things that are going on. So I don't know if we're ever going to be able to say like, oh, if we measure this one biomarker that we can modulate with any of our interventions, we'll be able to, relate this biomarker to quality of life. Like there's never going to be a quality of life biomarker. Like you just have to ask people, right? But I think just regulating a lot of these underlying mechanisms can help improve general health, which will improve quality of life.
So you would based on what you know and knowing the field, you would advocate that even for people that are not cancer survivors, who are not people under cancer treatment.
Oh, I mean, yeah, I think people who, nutrition is something that can help lots of people through lots of
I was
different
thinking about the
chronic
fasting
diseases.
schedule.
Yeah. I think it's healthy for everybody to eat fruits and vegetables and not eating after dinner. Like my mom is not a scientist and I'm telling her about my project and she's like, oh, wow, what a great idea. Like nothing good happens after 7 p.m. anyway. That's, when she's grabbing the ice cream or, when my dad's grabbing a drink, like she's like, hey, that makes sense. Like nobody's eating celery sticks at 10 p.m. So I think being on a schedule, not just an eating schedule, but a good sleeping schedule, a good exercise schedule, your body knows when it kind of expects like when it's going to need energy, when it's going to get food, when it's going to expend its energy. And I think that just helps. It can help everything be regulated better. And I think, and just thinking of like with aging in general, there's a lot of like just stress that can accumulate over the decades of your life. And I think the body just being able to predict how much energy it has, how much energy it's going to get in the next few hours, how much energy it's going to need in the next few hours. I think it just helps with like general metabolism stuff.
Great, thank
which-
you. There's another question, where it's a comment. Seems like time restricted eating might be good for academics too. With a little
Yeah.
one of those symbols next to it. Okay, thank you, Jason. Other comments or questions? Michael, I have a question for you. You're going to randomize patients and then refer them. Do you have a sense of what proportion those referred will actually take advantage of that referral? And how will you monitor that? Just sort of a methodologic issue.
Yeah, so I'll be finding out a bit of that really soon, as the referrals will be beginning now. I anticipate, so it will be closely tracked. We know exactly who will be offered the referral, and then the CBO will know who ultimately signs up. So we'll see the difference between who's been referred and who actually signs up. The CBO does their own intake as well. And so they may decide some people who are referred, they don't consider appropriate, and they will reject them, sort of send them back to the physician. So that's another possibility. So we will capture those data points from the CBO, really. So we'll see who the health system is offering the referral to, and then we'll see who the CBO actually receives, and then who follows through to completion.
Interesting. Other comments or questions?
I have a question.
Sora.
Sora,
Thank you. Hi, Dr. Lepore. My question is, now that COVID is over, would you also be interested in exploring in-person groups, or are you going to stay focused on the remote CBO?
So I appreciate the question. I'll be hesitant about saying over, but I would say there is interest in even the CBO that I'm partnering with. I believe they are offering some in-person groups, and they're finding that the signing up and the attendance for the virtual has been greater. So I will, as the pragmatism demands, stay aligned with what the practitioners are doing and will not guide them. If they are doing it virtually, then that's what I will study. If they shift to doing it in a mixed format or in an in-person format, then that's what I will study. But I'm really trying not to interfere with clinical practice and just research what they're doing. But it's an important question, Sora, and that was how the intervention was designed originally. So I would be interested in doing some work on the in-person and perhaps a 3-arm trial to compare the in-person, the virtual, and then no CST.
Well, we'll take one more question if there is one, and then we'll have to stop. It's already an hour has gone by. I think it's been a fascinating series of 3 talks. I know there's a lot more work in the psychosocial world going on at the university. And it's really, I hope that we can hear more of it as we go through this occasional seminar series. So thank you to the speakers, thank you to the audience, and it's still beautiful outside for those in the Baltimore area. I'm just looking out the window. So have a great afternoon, everyone. Bye all.